So we are entering the next part of the discussion of stroke. So we are about to complete the localization. So the localization is actually the toughest part, though it is easily done by CT or MRI. Clinically, a few things are important to know, like knowing the basic anatomy, important structures, important clinical features is important. So we'll complete the last part of localization and we'll proceed to the treatment and the remaining part. Over to Dr. Aravind.
Moving on to posterior cerebral artery territories, P2 territory mainly supplies the medial temporal and occipital lobes. Contralateral homonymous hemianopia without macula sparing is the usual manifestation. If the dominant visual cortex is involved, there will be unformed visual hallucinations, peduncular hallucinosis, metamorphopsia, teleopsia, illusory visual spread, palinopsia, distortion of outlines, central photophobia, hemivisual neglect, and simultagnosia. If the non-dominant calcarine and lingual gyrus is involved, there can be topographic disorientation and prosopagnosia. If the dominant calcarine cortex is involved, there can be verbal dyslexia without agraphia and color anomia. And we have certain syndromes, Anton syndrome, that is denial of blindness, bilateral homonymous hemianopia, color blindness with preserved pupillary reaction, and Anton syndrome, tactile naming, achromatographia, that is color blindness, failure to see to and fro movements, inability to perceive objects that are not centrally located, which is called as gun barrel vision, apraxia of the ocular movements, inability to count or enumerate the objects, tendency to run into things that the patient sees and tries to avoid. These are all manifestations when bilateral occipital lobe is involved.
These are actually the functions of the occipital lobe. So it is not just the vision, it's counting objects, picking up objects which are in the periphery of the vision. Okay. So if the occipital lobe is problematic due to P2 lesion, P2 territory lesion, even the vision may be normal, these things will be abnormal. So just because a person is able to see things normally, it doesn't mean that his vision is normal. So these are the higher functions of vision. So actually there's a separate entity called as lobar function test. For example, one of the occipital lobar function tests will be ability to count objects. So they may be able to see the object, but they may not be able to count. And they may be able to see the object, but they may not be able to differentiate the to and fro movement. So all these are problems with the occipital lobe. So and few name syndromes are there. We are not going into the details, but just know that there are some tests for peripheral lobe. There are some tests for occipital lobe. And if tested, we can find out there's an lobar stroke. Okay, we'll continue.
If the visual association areas are spared and only the calcarine cortex is involved, the patient may be aware of the visual defects, they say. Balance syndrome, that is bilateral visual association area lesion, a disorder of the orderly visual scanning of the environment, usually resulting from infarctions secondary to low flow in the watershed area between the distal PCA and MCA territories, as it occurs after cardiac arrest. Palinopsia, asimultagnosia can occur. Medial temporal lobe and hippocampal involvement can cause an acute disturbance in memory, particularly if it is in the dominant hemisphere. But usually it clears as memory as bilateral representation. We want to vertebral artery.
Can stroke cause loss of
Occlusive.
consciousness?
Yes, sir.
In Harrison, I think in one chapter, not in the stroke chapter, I think coma chapter in the end, they are given 5 causes of stroke with LOC. The reticular activating system, as you know, is a long tract which starts from the thalamus and descends through the brainstem. So any anterior brainstem lesion, like if the entire part of the pons is problematic, for example, in basilar artery thrombosis, or as you mentioned, previously, medial thalamic strokes. Okay, so involvement of any part where the reticular activating system goes can cause stroke. So median thalamic strokes, pontine strokes, and large area of infarct. A small stroke cannot cause LOC. So a large stroke involving one entire part of the cerebellum, or there may be LOC due to another reason. For example, in cardioembolic stroke, they may have LOC due to syncope, but stroke may lead to the neurological deficit. So there are and subarachnoid hemorrhage that can cause loss of consciousness. So they read Harrison also, but in addition to those given in Harrison, there are few other causes of stroke with LOC also. At least remember bilateral median thalamic stroke, basilar artery thrombosis, large strokes, cardioembolic stroke, and SAH. At least remember these five. Okay, we'll continue.
Occlusion of vertebral or posterior inferior cerebellar artery, as you all know, it can cause Wallenberg syndrome. Hemiparesis is not a typical feature of vertebral artery occlusion. However, quadriparesis may result from occlusion of the anterior spinal artery. They say. Again, medial medullary syndromes we all discussed. Cerebellar infarction can lead to respiratory arrest due to brainstem herniation from cerebellar swelling, closure of the aqueduct of the cerebus or fourth ventricle, followed by hydrocephalus and central herniation also. Uh, Subclavian steel. If the subclavian artery is occluded proximal to the origin of the vertebral artery, there is a reversal in the direction of the blood flow in the ipsilateral vertebral artery. So exercise of the ipsilateral arm may increase demand on the vertebral flow, which can produce a posterior circulation TAS. Another one notable point. So shall we move on to evaluation management, sir?
Yeah, continue.
As you all know, time is very important in management of stroke. For rapid recognition of stroke, they are proposing two like mnemonics for faster recognition. One is fast, that is face, arm, and speech involvement, and what is the time of onset for outpatient settings. And there is a scale called Rosier scale, that is recognition of
Fast also
stroke.
has been changed now. Now it is actually B fast. B for
Be fast.
balance problem. Yeah, E for eye changes. And fast. So a sudden onset of balance problem, sudden onset of ataxia, sudden onset of giddiness is also stroke. Sudden onset of any eye changes like diplopia. Okay, it is also stroke. So it is not fast, it is B fast. Balance, eye,
Yes,
face,
sir.
arm, speech, and time. Continue.
Oh. So this is the Rosier scale. Main parameters they have taken are loss of consciousness or syncope, seizure, and if it is present, it is like mostly moving away from stroke. And if there is a new onset asymmetrical facial weakness, arm weakness, leg weakness, speech disturbance, or visual field defect, these are points favoring stroke. So based on this, they are proposing it can be a stroke or not more unlikely to be a stroke. Even if the total score is zero, I mean one, it comes under a stroke and we need to evaluate further. So, this is the National Optimal Stroke Imaging Pathway, which is proposed in NICE 2022 guidelines, sir. For any suspected stroke in a person with persistent acute neurological deficit, they say in less than 20 minutes, if it is an acute stroke, plain CT with or without CT angiogram should be taken. And if we are after taking plain CT, if we rule out hemorrhage and it's more likely a ischemic stroke, and if the criteria for thrombolysis is met, they propose to give IV thrombolysis in the CT department within 5 minutes of imaging. And if uh, if the patient does not meet the criteria for thrombolysis, and it is a ischemic stroke, uh, further we can proceed with CT perfusion imaging. And if we see there is salvageable penumbra, again we can consider IV thrombolysis, which can be started in the CT department itself. And if it is a large vessel occlusion, we should not stop with the IV thrombolysis. We should proceed with the thrombectomy, which again should be in another within less than 5 minutes. On the other hand, if it is a very mild stroke-like symptom or a TA-like symptom, NICE 2022 guidelines suggest to take MRI with a diffusion weighted sequencing within 1 hour if possible. And if a carotid territory acute ischemic stroke is confirmed, then carotid imaging, that is Doppler, should be done within 24 hours. Is the cutoff they have given, sir. So overall, management of stroke, after assessing the airway breathing circulation, you have to obtain brain imaging to classify it is hemorrhagic or not. And if it is hemorrhagic stroke, the treatment is different, which we will talk in detail in another session. So if it is a ischemic stroke, whether it satisfies thrombolysis criteria or thrombectomy. Uh, After that, we have to establish the cause, like atrial fibrillation, carotid disease, or any other specific cause, and we have to treat accordingly. In addition, all stroke patients should receive DVT DVT prophylaxis, physical, occupational, and speech therapy whenever applicable, and secondary stroke prevention should be given. Hyperacute care, that is first 72 hours of after admission. There are certain time limits which is proposed in NICE 2022. So the overall ambulance call to needle time will be of less than 180 minutes. So all stroke cases should ideally be seen by a senior neurologist and his team. So from admission to consultation with the stroke specialist should be within 1 hour. So admission to a stroke unit, all stroke patients should ideally be managed in a separate stroke unit, which will be headed by a senior neurologist, followed by his staff nurse and other working staff. So the from admission to stroke unit, it should be less than 4 hours. And one of the main parameters deciding the outcome of the patient will be the door to imaging time, which should be less than 20 minutes. And the door to needle time should also be less than 20 minutes. Once you have got the image of a patient, from imaging to thrombolysis, the time should be less than 5 minutes, which they propose to do it in the CT room itself. And if it is a large vessel stroke, and we know the patient may require thrombectomy, again, from imaging to the thrombectomy pathway, it should be less than 5 minutes. And if it is a MRI or the diagnosis of uncertain, if it is a TIA or if the diagnosis is uncertain, the door to MRI time should be less than 1 hour. So if you identify a carotid territory stroke, carotid imaging, that is Doppler, should ideally be done within 24 hours. Uh, the treatment window for intravascular thrombolysis is 4.5 hours, but which can be extended depending upon the ischemic penumbra. Treatment window for mechanical thrombectomy is 6 hours. So from admission to assessment by all specialist therapists like physiotherapist, occupational therapist, clinical psychologist, speech and language therapist should be ideally within 24 hours of admission. In case the patient is deteriorating, the time to re-imaging should be less than 1 hour. And if the patient recently symptomatic significant carotid stenosis is there, uh, ideally it should be taken for carotid endarterectomy within 7 days of symptom onset. And if it's a non-disabling stroke or TIA, and if the patient is found to have carotid stenosis, the carotid endarterectomy should ideally be done within 24 hours. These are just the timeline which they have proposed. Regarding clinical signs, which can be helpful in determining whether it is a ischemic or hemorrhagic stroke. Again, it is not 100%. Patient presenting more of a depressed level of consciousness, higher initial blood pressure, or worsening of symptoms after onset usually favors hemorrhage. And if the deficit is maximum at the onset, or if it remits, again it suggests ischemia. Uh, Another one important concept is time of stroke onset, which they define as the time the patient's symptoms were witnessed to begin or the time when the patient was last seen normal. If the patient goes to sleep and he gets up with a stroke, then the last seen normal will be the time which he went to sleep. Moving on to CT imaging, non-contrast HCT is the imaging modality of choice in patients with acute stroke because of its speed and wide availability. CT angiogram and CT perfusion imaging are adjuncts to the management of stroke. Contrast enhanced CT scans, they add specificity by showing contrast enhancement of subacute infarcts and allow visualization of venous structures. CT angiograms can identify and quantify atherosclerotic stenosis of the cerebral arteries and also other pathologies including aneurysms, vasospasms, intraluminal thrombi, fibromuscular dysplasia, AV fistulas, vasculitis, and collateral blood flow. CT perfusion is mainly to pick up ischemic penumbra. So there are immediate indications for non-contrast CT in a suspected acute stroke. The patient is having severe headache at the onset of stroke symptoms, or if there is papillary edema, neck stiffness, or fever on presentation, or if the GCS is less than 13, or if there is unexplained progressive or fluctuating symptoms, or if there is indication for thrombolysis or thrombectomy, or if the patient is on oral anticoagulant treatment, or if he is having known bleeding tendency. So these are immediate indications for doing a non-contrast CT. Again, if a thrombectomy is planned, following the initial non-contrast CT angiogram, and if required, CT perfusion imaging can be done. Without immediate indication, like which I mentioned above, CT should be performed in all cases of suspected stroke within 24 hours of neurological symptom. On to MRI, diffusion weighted imaging is more sensitive for early brain infarction than the standard MRI sequence. MRI with the fat saturation is an imaging sequence used to visualize extra or intracranial arterial dissection. There is something called ion sensitive imaging. It is helpful to detect cerebral microbleeds that may be present in cerebral amyloid angiopathy. On to ultrasound imaging, duplex ultrasound can pick up stenosis at the origin of the internal carotid artery and can be quantified. Transcranial Doppler can detect stenotic lesions in large intracranial arteries and also can detect microemboli from otherwise asymptomatic carotid plaques. Perfusion techniques, both xenon techniques and positron emission tomography can quantify the cerebral blood flow, but it is used mostly in research purposes. Moving on to the criteria for intravenous thrombolysis. Once you know the patient is having ischemic stroke and there are certain criteria for proceeding with intravenous thrombolysis. First criteria is that intracranial bleed must be excluded. We should be window period of within 4.5 hours. There should be trained staff to administer and monitor for complications. And in case of deterioration, there should be facilities for re-imaging. If all four criteria are met, we can proceed with intravenous thrombolysis. Moving to the intravenous thrombolytic agents, we have alteplase, tenecteplase, which are recombinant tissue plasminogen activators. Uh, According to the NINDS, that is National Institute of Neurological Disorders and Stroke study, which they used intravenous alteplase at a dose of 0.9 mg per kg to 90 mg maximum, out of which 10% is given as bolus and the remainder is given over 60 minutes. Uh, Versus placebo. This in this study, the time limit was within 3 hours of onset. They found the uh, effects of alteplase in improving the outcome. So based on this, we are giving alteplase, and to extend this study beyond 3 hours to up to 4.5 hours, uh, European Cooperative Acute Stroke Study 3. This was the first randomized trial to evaluate whether there is benefit of thrombolysis in ischemic stroke patients between 3 to 4.5 hours after the symptom onset. So based on which it was approved for use beyond 3 hours up to 4.5 hours. Again, both the studies, the age cutoff was 18 to 80 years. This alteplase, it decreases the probability of disability, but survival outcome has not been proven. So if the criteria for thrombolysis is met, we should know the indications and contraindications. Uh, Contraindications for thrombolysis are if the BP is persistently high, that is more than 185 systolic and 110 of diastolic despite treatment, and if there is known bleeding diastasis, or if there is a recent head injury or intracerebral hemorrhage, or if there is a major surgery in preceding 14 days, or GI bleed in the preceding 21 days, or a recent MI. Again, to administer alteplase, there should be 2 IV access peripheral IV line, a dose of 0.9 mg per kg, which we discussed. There should be frequent BP monitoring, and following administration, there should be no other antithrombotic treatment for at least 24 hours. If there is decline in neurological status or if the BP is uncontrolled, we should immediately stop the infusion, give cryoprecipitate, and re-image the brain emergently. And it is better to avoid urinary catheterization for at least more than 2 hours. So bleeding following use of IV thrombolytic agents is another huge complication. Asian patients have higher propensity to bleed from most of the antithrombotic and thrombolytic medications. In countries like Japan, they are using at a lower dose, that is 0.6 mg per kg. So there is an ongoing trial, that is IST3 trial, that is international third international stroke trial, where they are being trying up to 6 hours from the stroke onset for IV thrombolysis. Another important agent is tenecteplase. Is given at a dose of 0.25 mg per kg bolus over 5 seconds. There is no need for infusion. It improves the efficacy of transportation. But there are no direct trials and comparison between tenecteplase and alteplase and which is better. Tenecteplase is generally safe. Moving on to thrombectomy. So proximal and occlusion of the proximal anterior circulation, which is demonstrated by CT or MRI angiogram within 6 hours, along with intravenous thrombolysis, thrombectomy should be tried. And if there is occlusion of the proximal anterior circulation, which is demonstrated with CT or MRI, between 6 to 24 hours, if there is salvageable brain tissue on perfusion or diffusion weighted imaging, again thrombectomy can be proceeded. For posterior circulation, within 24 hours, if there is salvageable brain tissue on perfusion, uh, in addition to intravenous thrombolysis, we can go for thrombectomy, because when compared to anterior circulation, the morbidity and mortality is higher with posterior circulation. So even though it is out of window period for thrombolysis, still if there is salvageable brain tissue, even up to for 24 hours, we can try both thrombolysis and thrombectomy is what is the recent concept. Uh, some trials supporting the use of thrombectomy, like Dawn trial, Diffuse 3 trial, and Basics trial. Dawn trial is the clinical mismatch in triage of wake up and late Pacific strokes undergoing neuro intervention with Trivo. This is again an instrument name. It reported good outcomes more frequently with endovascular therapy than with medical care alone. Diffuse 3 trial, the endovascular therapy following imaging evaluation for ischemic stroke 3, it confirmed the results of good outcome if treated up to 16 hours from the stroke onset. Then we have basic style, the basilar artery international property study. In a confound basilar occlusion, people randomized with standard care and in additional intra-arterial therapy within 6 hours of onset. The results were good. So IV thrombolysis combined with thrombectomy has improved outcomes when compared with thrombectomy alone. But again, it has to be individualized. Pre-functional, pre-stroke functional status, clinical severity of the stroke, the extent of the established infarction on the initial brain imaging, all should be considered as a part of decision making, because there is no standard criteria for recommendation. Again, thrombectomy improves the functional status, but it has got no clinical difference in mortality. Again, carotid stenting is another less invasive approach. It can be tried for a symptomatic carotid artery disease, which I'll be talking later. So moving on to antiplatelet therapy. Aspirin is the only antiplatelet agent that has been proved to be effective for the acute treatment of ischemic stroke. As soon as ICH is excluded, they recommend aspirin at 300 mg. If the patient is having difficulty in taking oral drug, it can be given through an enteral tube or per rectal. NICE 2022 suggests to continue for 2 weeks uh, uh, initially, and then dose modifications. Some patients may be aspirin intolerant. Aspirin intolerance is defined as either proven hypersensitivity to aspirin containing medicines or history of severe dyspepsia induced by low dose aspirin. So, for secondary prevention of stroke, we have several antiplatelet agents which have been proven to reduce the risk of stroke. So, other two antiplatelet agents, especially clopidogrel and ticagrelor, uh, has been proven to be effective in preventing secondary stroke. Uh, they prefer to use the ticagrelor because of the cytochrome P45 2C19 polymorphism, which we encountered with the clopidogrel, especially in Asian descent patients. Whether aspirin alone or we should combine another antiplatelet agents in the treatment of acute phase of ischemic stroke is still a debate. Again, there are trials for antiplatelet agents in acute stroke. Chance trial. This was conducted in Chinese population. Uh, they used clopidogrel for it. Clopidogrel in high-risk patients with acute disabling cerebrovascular events. They combined clopidogrel and aspirin. Uh, they gave a loading dose of clopidogrel 300 mg, followed by dual antiplatelet agents, clopidogrel 75 mg and aspirin 75 mg for 21 days, followed by single antiplatelet therapy, that is clopidogrel 75 mg alone. And they found out it reduces the risk of stroke in the first 90 days, and the risk of hemorrhage is also not high when compared to using aspirin alone. So based on this chance trial, there was point trial, uh, which was a more multi-centered trial following that is oriented inhibition in new TIAs and minor ischemic stroke. They again the loading dose is different. Like, in point trial, they gave a loading dose of clopidogrel 600 mg, followed by dual antiplatelet agents, clopidogrel 75 mg and aspirin. Low dose aspirin, they suggest, can be ranging from 50 to up to 325 mg for up to 91 days. For up to 90 days, they are suggesting. Again, this has shown to prove the same results, that is in reducing the risk of stroke, and again does not increase the risk of hemorrhage. And we have other trials for other agents like Socrates trial for ticagrelor, but again it was not found to be superior to aspirin. And we have Thales trial for combining ticagrelor and aspirin. Uh, the risk of stroke was lower in patients who received a combination than who received aspirin alone. And we have TARTIS trial, that is triple antiplatelet therapy, that is clopidogrel, aspirin, and dipyridamole combination. Again, the risk of hemorrhage was higher, so it is not advocated. Moving on to anticoagulant therapy. So, anticoagulation is not routinely recommended for the treatment of acute ischemic stroke. For acute venous stroke, full dose anticoagulation is recommended. Either full dose heparin and then warfarin bridging with a target INR of 2 to 3. And if the patient with ischemic stroke develops as symptomatic proximal DVT or pulmonary embolism, again full dose anticoagulation treatment should be given. If the patient is having hemorrhagic stroke and there is symptomatic DVT or pulmonary embolism, to prevent the development of further pulmonary emboli, either you can go for anticoagulation or IVC filters. Again, pneumatic compression stockings are a safe alternatives to heparin. And we have certain special situations like acute ischemic stroke secondary to arterial dissection or antiphospholipid syndrome. In acute arterial dissection, either anticoagulants or antiplatelets can be given to people who have stroke secondary to acute arterial dissection. In antiphospholipid syndrome, again, there is insufficient evidence. So the management is the same as that of acute ischemic stroke without antiphospholipid syndrome. If the patient, ischemic stroke patient, is at higher risk of going in for hemorrhagic transformation, they advise to stop anticoagulation treatment for at least 1 week and substitute aspirin only as the only treatment. So again, there is a controversy in statin use. They recommend not to use statins in acute stroke patients, sir. But Harrison says to use atorvastatin 80 mg with LDL target of less than 70 unless the stroke is a non-atherosclerotic cause. And if the patient is statin intolerant, they suggest to go with PSK9 inhibitors. So in addition, there are several other parameters to look in the complete management of stroke. So monitoring homeostasis, there is no role for supplemental oxygen and its routine use in patients who are uh, acutely having for acute stroke patients who are not hypoxic, and the target blood sugar level should be between 72 to 200. Again, fever is detrimental in stroke, so it should be treated appropriately with antipyretics and surface coolings. Again, blood pressure control in acute ischemic stroke. So rapid blood pressure lowering should only be offered if there is an hypertensive emergency, uh, like hypertensive encephalopathy, hypertensive nephropathy, or hypertensive cardiac failure, or myocardial infarction, aortic dissection, or associated preeclampsia or eclampsia. And as we discussed earlier, for intravenous thrombolysis, the cutoff is 185 or 110. And all stroke patients should have their swallowing assessed. Before giving food, fluids, or medications, it should be assessed. Should ideally be done by a specialist within 24 hours. If there is difficulty, nasogastric tube feeding should be started. If they are not tolerating nasogastric tube, gastrostomy or nasal bridle tube should be used. For detailed nutritional assessment, the patient should be referred for individual plan. Again, nutrition. Routine nutrition supplementation is not recommended for people with acute stroke who are already adequately nourished. And people who are having acute stroke who are at risk of malnutrition, nutrition support should be started. There are several screening tools, one of which is must tool, that is malnutrition universal screening tool. When positioning of patient with acute stroke, so individuals' clinical needs and personal preferences should determine the optimal head position. Patient's comfort, physical and cognitive abilities, postural control, everything should be taken into account. Early mobilization. Patients should be made to sit out of bed or allowed to stand or walk as soon as their clinical condition permits. If a patient is requiring support to even sit or stand or walk, again, high intensity mobilization is not suggested, especially in the first 24 hours of symptom onset. High intensity mobilization is it begins within first 24 hours of stroke onset, includes at least three additional out of bed sessions compared with the usual care. It focuses on sitting, standing, and walking, that is out of bed activity.